Hello, this is Hillary Cummins. Thank you, Kristen. I'm not sure if you were able to see the slide being advanced.
I am not.
So let us just pause to arrange the technical aspect and figure out how to make sure the participants can see the advancing slide.
Okay. This is Kristen Woodlock. Hillary and Hank, one thing that we could do is move Hillary to be the presenter. It appears that I'm the presenter, so I think that will solve that issue. And meanwhile, I'll jump in on some of the housekeeping issues. So just in terms of housekeeping, our understanding of the COVID-19 pandemic is evolving rapidly. This presentation is based on our knowledge as of today at 10 a.m. All of the participants will be muted, but as we discussed, there will be time, we hope about 20 minutes for questions and answers. And please type those in the question and answer box that you'll find on the side of your screen. In terms of the panelists, we just would like to recognize that there have been many people who contributed to the content that we're going to share with you today. These individuals will also be available during the question and answer session as well. So a thank you to them. And Dr. Cummins, I will turn it over to you to start out with the agenda.
Sorry, Hillary, you're unmuted now.
Hi, everyone. Again, I'm speaking to myself. We are having a couple of technical difficulties this afternoon. Apologies. I want to thank everyone for joining us this afternoon. First of all, I want to acknowledge the many participants from really across the mental hygiene sector. This is a broad presentation intended to provide some updates around COVID-19 in New York City and some of our local data, provide some information about infection control guidance, and then to do a scan across our collective programs to share with you the information that we have about the kinds of services that are currently operational and in what format. We want to share with you some city work around isolation hoteling that is now available to providers in the behavioral health sector, contract flexibility and access to additional funding. And we intended the primary audience for this webinar to be folks that are in contract or have subcontracts with the New York City Health Department, but are aware that much of the content is really relevant to a broader group of people. Finally, we'd like to share support and resources that are available for your work and staff. I'm getting a note that our volume might be a bit low, and if it's still a problem, please just type in and we'll try to fix that. So where are we right now in terms of the COVID-19 pandemic? I think as everybody is well aware, there's still widespread community transmission, both here in New York City and around the world. And it's hard to believe that it has only been 7 weeks since New York City reported its first confirmed COVID-19 case. And since that time, I think it's fair to say for every single person here in New York City and really across the world, all of our lives, both professional and personal, have changed. Here in New York City, we are continuing to see high numbers of people who are diagnosed, including those who require hospitalization. But we might be, and this is cautious optimism, begun to flatten the curve. Our data and statewide data show an improvement in emergency department visits as well as hospital admissions. But at the same time, we know that we cannot let our guard down and reinforce all of the mitigation measures that we know to be working. I want to share with you over the next couple of slides some of the New York City data all of the data that I'm about to show you, or most of it is available on our website as well and updated at least for these first few slides on a daily basis. So this first slide shows a graph of hospitalizations in New York City starting from March 2nd, the beginning of the pandemic in New York City, and goes through April 14th. And you can see a rapidly increasing curve where the blue bars represent number of hospitalizations to New York City hospitals, and the bottom, across the bottom, are the dates starting, as I said, March 2nd, going through April 14th. I'll just caution you that there are delays in reporting from hospitals, so some of the more recent days are incomplete. And though the slope is, in fact, decreasing, it will fill in over the next couple of days as reporting becomes more complete. On the next slide, I wanted to share with you a new way we are reporting New York City deaths. At the beginning of the pandemic here in New York City was reporting only confirmed deaths. That is, people who had died and had also had a laboratory confirmed case of COVID. As of last week, we are also reporting what we consider probable deaths. And what you can see in the graph in front of you in orange bars are the confirmed deaths, again, starting early March, going through April 14th in this case, and in blue bars, the probable deaths. These are deaths where on somebody's death certificate, the death is reported as probable or likely COVID even without a lab test. So as of April 16th, we have lost more than 10,000 New Yorkers to COVID. And we know, unfortunately, we are likely to see more deaths coming in the next coming days. What I'll also point out to you on this graph is that it does appear that deaths are beginning to decrease. We consider deaths what's called a lagging indicator, meaning we expect to see decreases in hospitalizations before we see decreases in deaths. Some of the folks who are passing away now are people who have been ill and in the hospital for some time. Finally, I want to share with you an additional aspect of our mortality data here in New York City. Similar to reports that have happened nationally in other cities and states, we know that our New Yorkers of color are experiencing higher rates of mortality and hospitalizations than white New Yorkers and Asian New Yorkers. So what you can see starting from the left, going to the right, the blue chart shows that Black New Yorkers and Latino New Yorkers who have lab-confirmed cases of COVID, Blacks have the highest rate, followed by Latino New Yorkers. Among hospitalized New Yorkers, which is the middle set of bars, we can see that the same pattern holds true. Black New Yorkers, followed by Latino New Yorkers, have highest rates of hospitalizations due to COVID. And then finally, unfortunately, that pattern also holds true among people who have experienced fatal COVID with Blacks, then Latinos, whites, and then Asians. I just point out that these data are not complete because of reporting, because of the way these different data gets reported. And you can see that in only 24% of cases that are not hospitalized do we have data about the person's race or ethnicity, slightly better for hospitalized patients and for patients who have died. We also want to share with you some of the other indicators that we are tracking in this pandemic, specifically around behavioral health. Most of these data come from emergency department visits, which we track using a system called syndromic surveillance, which are reports from emergency departments. Some of our key indicators include anxiety-related emergency department visits, which are below the threshold that we observed in 2019, which is the dotted line that you can see in front of us. A similar pattern holds true for depression-related emergency department visits, which are lower than we saw in 2019. Similarly, for suicide, there are lower visits because of suicidal thoughts or behaviors compared to 2019. In terms of overdose, we saw a dip, what appeared to be a dip, in late March for overdose-related emergency department visits, and seems to have come a bit back up to approximately 2019 thresholds later in April. And finally, alcohol-related emergency department visits are also lower compared to what they were in 2019. We believe that for many of these, it is because there's been a lot of messaging from the city to avoid the emergency department because they have been so very burdened by COVID-related emergency department visits. However, we remain concerned because we know that these particular problems, as well as other behavioral health concerns, don't disappear, and in fact could be heightened during these very stressful times. I'm going to back us up because I got myself out of order, and want to share with you another metric we are tracking, which is calls that have been answered by NYC Well. I am guessing, as I hope that most of this audience knows, NYC Well is the New York City helpline that can help in behavioral health crisis and make referrals to care, or including crisis care. So we know that that service stands ready to help New Yorkers, and weekly calls are represented on this graph with the number of weekly calls starting the week of March 8th and going through the week of March 12th. You can see along the middle of the your screen what the 2019 average was, and you can see in late March those calls increased, and by calls I mean calls, texts, and chats, and we expect that and hope that people will continue to seek help through this means as well as others. I'm going to skip the slides that I had just shared with you, and now move on to some of the guidance and actions that we have taken and that all of you are taking. As you know, a key part of the control of transmission of COVID for all of us is to prevent its spread. I want to share with you some of the key materials that are available on our website for download in many languages and many different styles, depending on your audience. And I encourage you to feel free to use these, download these, and post them wherever you feel relevant for yourselves, for staff, and for clients. As you know, our key guidance has been consistent over the last week in many weeks in many of the areas, and I want to just highlight some of the newer guidance. The first, which is to stay at home whenever possible, has been a guidance since late March. The next bullet is a new guidance, which is to wear a face covering when outside, whenever possible. By face covering, we mean, as I believe you are likely will have heard, is a non-medical mask. As PPE continues to be in short supply, we are encouraging folks to prioritize PPE for the great variety of healthcare workers, including those of us in the behavioral health sector, but to use a face covering in settings where No physical touch is needed with somebody with suspected or confirmed COVID. Those face coverings can be easily made using a scarf or t-shirt or other very simple strategies. Other strategies have been unchanged: to wash hands frequently for at least 20 seconds and to clean and disinfect regularly, particularly high-touch surfaces like doorknobs and counters. One aspect of the coronavirus is that it is quite susceptible to routine cleaning materials, and the virus is very easily killed just using fairly routine disinfectants. Specific names of those disinfectants are also available on our website. I wanted to just share with you some of the basic guidance that we have also made available on our website. And these are some aspects that we thought would be relevant in particular for outpatient behavioral health providers who may not have access easily to physical healthcare providers and who might be concerned about when to advise a client to stay home or when to have a client seek a higher level of care. So some basic points that we think are relevant for all of you are to communicate to clients when they might seek a physical healthcare provider. If the patient or client is 50 years or older or has other pre-existing health conditions such as heart problems, lung problems, or diabetes, we recommend they consider consulting a medical provider at the outset of symptoms. For other people, if symptoms get worse, or for anyone, if symptoms get worse or don't go away in 3 to 4 days, we also advise seeking medical consultation. And we advise people to seek medical consultation by telephone, to call a provider, as many outpatient providers have switched to either phone call consultation or telemedicine. We also recommend that clients are advised to seek urgent medical care for more severe problems like difficulty breathing, persistent pain or pressure in the chest, new confusion, inability to stay awake, bluish lips or face, or other health emergency. The health department has certainly messaged to avoid using 911 or the emergency department for non-emergencies, but we want people to know that the emergency departments continue to be available, and 911 is absolutely available for these emergency situations. In fact, EMS visits or runs have been decreasing and are nearly at where they were before the pandemic began. So there is capacity right now, and we encourage people to use 911 in cases of emergency. And then finally, as I already mentioned, encourage clients to call, email, or use telehealth rather than getting in-person care, except in cases of emergency. Another question that has come up on these webinars, as well as other settings, is that clients with symptoms, as when clients can be advised to stop isolation. And the following are the key points to keep in mind. At least 7 days have passed since isolation started, and they never had a fever or have not had a fever in the past 3 days. And that means without the use of fever reducers. And overall, their illness has improved. We encourage you to share this information with both staff and clients, and all these slides will be posted, and the guidance is also available using the FAQs on the front page of our health department website. And you can see the websites and resources that I mentioned here, as well as more general mental health resources and children and family resources. So I want to take the next few minutes to share with you very briefly and at a very high level a scan that we've conducted, reaching out to many of you, about how the services have, and in some cases are exactly the same in the mental hygiene, behavioral health sectors. And so this will be, these next few slides will be a little bit of a laundry list. And I know that there are some people who are probably more and less familiar with these different services. So I will try to define them as I go through them. So in terms of the various kinds of mobile, clinic, and field-based mental health treatment, much of those services are being conducted via telehealth, but in-person services are often available, but are generally reserved if the person is in crisis or needs an injectable medication. Our assisted outpatient treatment program continues to investigate referrals and monitor adherence to court-mandated mental health treatment and care coordination. As many of you will know, that New York City Health Department operates what is called a SPOA, or single point of access, to gain access to intensive mental health services, including care coordination and mobile treatment. And those SPOA is open and receiving referrals, and we are making referrals to those services. Our co-response and HEAT teams are operating telephonically, engaging with past or already enrolled clients. These co-response teams are folks where we pair a clinician or social worker with a police officer to engage with people who might be at heightened risk of harm to self or others. Those teams are not making street calls, but are following up with past clients. Similarly, for our health engagement and assessment teams, in which a peer worker is paired with a clinician, and they are engaging with already enrolled clients. Our START program, New York Supportive Transition and Recovery Team, which is a team that engages with people for a first or following a first episode of psychosis. That team is continuing to receive referrals and is offering services via phone and video. From our state colleagues who have oversight of inpatient psychiatric care, we know that there have been some consolidation of inpatient services as some of the inpatient psychiatric wards have been made available to the medical services as they've needed to surge to care for people with COVID. Some of that acute consolidation has transferred patients to New York State psychiatric centers, as well as some of the acute care. Importantly, the psychiatric emergency department services have been aggressively connecting with assertive community treatment teams, or ACT teams, and using critical time intervention so that folks presenting for crisis in psychiatric or psychologic crisis in emergency departments are quickly and effectively connected to ongoing mental health support. In the substance use sector, I want to mention, importantly, opioid treatment programs, congregate residential care for addiction treatment, syringe service providers, and opioid prevention programs dispensing naloxone. So in general, those services, particularly for outpatient drug treatment, have tried to convert to continued treatment via telehealth, with some availability in person using physical distancing. We have worked closely with our colleagues at OASIS, who are able to offer, under federal waiver and state support, longer take-home dosing for methadone, which enables people to more effectively physically distance, stay home, and stay safe. Syringe service programs are considered also essential services. We are aware of some continuing to operate, and as well as some with staffing difficulties and some pauses in services. Finally, we are also aware that opioid overdose prevention programs are continuing to dispense naloxone. We encourage people to call ahead to check with hours and make sure it's still available. Oh, and I skipped ahead of myself to talk about overdose prevention and naloxone, so I've already mentioned those. I'll also mention buprenorphine access in primary care is ongoing. Many of the primary care sites offering buprenorphine have continued using telehealth and in person as needed. And I want to make this group aware of the New York City Health and Hospitals virtual buprenorphine clinic that has the capacity to treat all New Yorkers at low or no cost. Continuing on with the substance use theme, the DOHMH operated relay program, which sends peer workers into emergency rooms or departments, suspended response to emergency departments in March because emergency departments could not accommodate staff as they were very taking care of folks with COVID. However, wellness advocates remain on call 24/7 and are working with people who experienced an overdose and enrolled in relay. Turning to systems for people with intellectual or developmental disability, many of these community services are continuing to be delivered via telehealth and, when needed, in person using physical distancing. Some of you may have participated in our webinars over the last 2 weeks in which we focused on congregate settings and addressed many of the challenges and opportunities in congregate settings serving communities with intellectual or developmental disabilities. In terms of housing, we want people to know that supportive housing is continuing to review applications, and you can see there that the New York City Human Resources Administration is reviewing the 2010E applications for housing. They have made modifications, which include remote interviewing, and moving into new apartments is continuing. There are some exceptions, but that program is continuing to go forward. The message that I also want to carry to you is we want you to please keep your organization's availability up to date on NYC Well, including detail on service delivery approaches such as in-person and or telehealth. This has been an effective way for us and to communicate out to people looking for help about how best to seek help and how best they can obtain it. So for those of you representing a program, please, I hope that you will take that message back to your program director or manager to be sure that that information is up to date, and we thank you for it. I want to switch topics and speak briefly about isolation hoteling as part of the city's offering during the COVID pandemic. Right now, hotel rooms are available to New Yorkers who may have symptoms of COVID or who have been diagnosed with COVID and are unable to isolate where they live. These hotel rooms, and I'm looking at the bottom section of the slide, going a little bit out of order, these are for folks who do not need COVID-related medical care, can be isolated in hotel rooms with limited services, meaning what is available in these hotels is food, laundry, and some sort of wellness check. If a client or resident needs ongoing services, the hotel can often accommodate the client if the provider can provide some support at the hotel. That includes telephonic support, but the ability to visit with a client if needed in person. We have opened the isolation hoteling up to congregate residential settings where people cannot isolate in place, and specifically funded or licensed by New York State Office of Mental Health, New York State Office of Addiction Services and Supports, New York City Human Resources Administration, or us, New York City Department of Health and Mental Hygiene. Of note, which I'm not going to address here, is the City Department of Homeless Services also has an isolation hoteling program, which is operating a bit separately from this, but also in concert being operated by the New York City Office of Emergency Management. We expect that hoteling will continue to be part of the city's response to the pandemic, even as cases decrease. We will anticipate a need for ongoing hoteling or isolation options for folks that we are providing services to or care to. Lastly, I want to share with you some information about contract flexibility and access to additional funding. We know that these are really unprecedented times in all ways, and that includes how we, the city, and how you as a provider need to have resources available and how we need to make them available. So the city is aiming to be as flexible as possible with that in mind. We ask that contracted providers speak with their program consultants or specialists about budget modifications or requests for additional funding so that they are able to respond to pandemic-related needs or costs. Subcontracted providers, which are in contract with either Public Health Solutions or the Fund for Public Health in New York, should speak with one of those two bodies, as well as their New York City Health Department point of contact to discuss budget modifications and payment. Unfortunately, at this time, our guidance is that city council funded or designated contracts cannot be modified at this time. And we will keep you up to date if that changes. And finally, I want to just share with you support and resources for staff. And before I get to the specifics, I want to really extend my thanks to all of you who are doing this very hard work at this time. I can speak for us at the Health Department that this is surely an extraordinarily difficult time. We have already lost colleagues here at the Health Department. Our staff have lost family, friends, loved ones. And I know that all of you are going through that too, and all of us need to both take care of ourselves and take care of the people we work with, as well as our clients. We have put out a number of different guidances, and that we hope will be useful for you. And you can see on our website, and I see somebody typed in a question, where can we get this material? All of our materials are available on the DOHMH website. If you simply Google DOHMH COVID, our page will come up, but you will have these slides posted, so you'll be able to navigate to them directly. I'll also want to share with you some other resources, which is that there are grab-and-go meals at more than 400 locations, most of which are city schools, and you can find them there to access food for clients. Finally, the city has stood up what are called regional enrichment centers for children who are children of essential service workers, including behavioral health and intellectual developmental disability workers. These are places that can provide childcare to your families, including food and other support. New York City Well, which I've now mentioned a couple of times, is available to all of us as New Yorkers. In addition, on the New York City Well website, you can see a number of digital mental health resources. So for staff, for clients, or for yourselves, these are excellent resources for both self-care and ways to refer people who might need some support. So I'll end, and I know lots of questions are coming in, and Kristen is going to help us, but I really just want to end by, again, thanking everyone who joined us today. We're trying at the City Health Department to provide information that is useful, and it is, I know, a challenge in times where it seems like guidance and information changes on almost a daily basis. We are all learning together. We are inventing new ways to respond. I've been so heartened by the amount of creativity and compassion and that all of the behavioral health sector has been displaying, and all of the feedback and questions that we get. We are trying very hard to be responsive and honest and as clear as we possibly can. I also want to make you all aware that, and again, responding to a couple of the more medical questions that have popped up in the question box, the City Health Department is also holding a weekly medical provider call. And again, you can access this on the DOHMH provider site, and you can just sign up and listen into that webinar. And it is happening more or less on a weekly basis and mostly covers the more medical agenda. So I'll turn us back to Kristen, who will help us field some of the many questions that have come in. I thank you all very much for listening.
Thank you, Dr. Cummings. Appreciate that. Let's start off with some questions about hoteling. And so one question that we have is that is it possible, do we know if it's possible, if we have a client that is at the hotel, is the provider able to send meals or care packages to that individual at that hotel?
Oh, so they can certainly send care packages and send anything they want. The provider does not need to have the client send the client meals because the hotel will provide it. But it is very easy to send things to the client or the patient via the front desk. So, for example, if a client needs, I don't know, more deodorant or shampoo, it's very easy to drop that at the hotel or send that to the hotel, and the hotel will get it up to the client's room.
And we have a couple of questions about how to access the hoteling, about, whether you're an OASIS provider or a mental health provider, how would you access that hoteling?
Sure, and I may ask, we may need to get back to people on the exact mechanism. So all congregate care providers who are eligible to access hoteling have had a communication from their state agency or from us on how to access it. Our point of entry is a not-for-profit called Shinny, and eligible programs have gotten that communication. If you are have not, and you're welcome to get in touch with your program specialist or consultant here, or your state agency if you are funded or regulated by them, to find out whether you're eligible and what the mechanism is. And if you are a congregate provider, you should be eligible.
Great, thank you. And also on the New York City well, you had asked all of us to be, attentive to that, to update our information on New York City well. Is there a contact person that we should be communicating with, or is there a site on that we should be doing that?
I'm going to turn that to Mila Harrison to answer.
Hi there. Can you hear me?
Yes.
Wonderful. In order to update your NYC Well information, that is actually on the NYC Well site under the resource guide. And I think if Jamie Nichols is on the phone, if that is not correct, she should jump in and correct me.
That's correct. Can you hear me? You can update via the provider tab on the NYC Well website. I also just communicated an email address in the chat section for the resource manager at NYC Well. If you all go to the chat, you can see that email address, I think.
Okay, thank you. We have a question specifically about children's mental health, that the home-based crisis intervention programs aren't receiving referrals as they have been in the past. And, except for the mobile crisis, what other resources are available for children for mental health?
I'm going to tap Marnie Davidoff to help answer that question more fully.
Hi. So the home-based crisis intervention programs, I'm not sure if I'm interpreting the question correctly. We have been tracking to ensure, to track to see if they are at capacity or over capacity, and most of them do have some capacity in them, so there should be opportunity to take in new cases. I would love to just better understand if there's an obstacle to referring that is getting in the way of that. And in terms of crisis services, yes, the Children's Mobile Crisis Teams continue to be operational and continue to be accessible through NYC Well. So if there is follow-up information on the specific obstacles in terms of making referrals to home-based crisis intervention, I'd be more than happy to follow up offline with that individual.
Sure. Thank you, Marnie. Appreciate that. So another question in terms of the Governor Cuomo's mandate about wearing some kind of face covering in public, and is there a way for programs to be able to access some of those to hand out to participants? It's something that they are being asked very frequently.
Yes, and we are asked that. We are also being asked that very frequently, and I appreciate the question. So first, I just want to clarify that the face coverings, again, can be cloth masks or homemade masks using a scarf or even a t-shirt. There are some excellent YouTube videos about how to convert a t-shirt into a face mask. So at this point, what I'm aware of is the city is, we do not currently have a mechanism to make those available, but please stay tuned because that is certainly a question we are getting a lot. But that said, there are some innovative ways to do that. Other cleaning supplies and so forth, I think if there is something that you need for your program and you are in contract with DOHMH, please ask your program specialist or contract specialist to learn whether you can use some of your budget for those supplies, including cloth masks.
Great. Thank you. Sort of going back to the earlier parts of your presentation when you were talking about the impact of COVID-19 on various communities, do we have any insight as to why there's a lower impact on the Asian community here in New York City?
Well, I'm going to flip the question, if I may, Kristen, and why there's a higher impact on African American and Latinx communities. And I think that this is something that the health department is extremely concerned about. We have a number of initiatives to focus on specific communities of color that have seen higher rates of hospitalizations and deaths in terms of education, in terms of standing up clearer points of access into the healthcare system. I think that as we've observed in many health conditions that are a result of the social determinants of health, including structural racism, that this is not unsurprising that we're seeing this play out in the same way. And like other health conditions, we need to really center equity and strategies to reduce inequity if we're going to hope to see different health patterns. Why Asians have the lowest rate, I think, is a matter of speculation at this point for us. And, I think I encourage all of us to stay to continue to watch that pattern and understand whether that continues to be true as this epidemic evolves.
Thank you. Next, we have a clarification on, I believe, on the 3 and 7 factors that you shared with us in terms of not being in isolation. So if a staff person of ours has had a fever, cough, chest pressure for more than a week, the fever goes away, but they're still coughing, is it safe for them to return to work?
So what we would recommend is it is safe after 7 days after symptom onset and at least 3 of no fever and improvement of symptoms. So if that symptom persists and without improvement, the recommendation would be to wait until there is improvement. With viral infections, including this one, the symptom of cough can continue for some time. And so absolute resolution of cough is not needed because the person is coughing does not mean they're infectious.
Okay, thank you. Next, we have some questions related to some of the data that you shared, and it may be the person asking this question, did preface this by saying that they totally understand if there's a lag in data or we don't have this information, but thought they would ask the questions anyway. Do we have a sense in March why the decreases in emergency room visits, for areas that we would consider indicators for our field? Is that because people were staying home? Is that because of a capacity of first responders? Do we have any insights or, causality kinds of thinking around those?
So, we'll never know for sure. It will be hard to know for sure. We have hypothesized that it is because the city was we all were aggressively messaging to people to stay home for anything other than an absolute emergency in order to allow the emergency department to handle the surge. That said, we in the health department don't look at it as a success necessarily. It leaves us feeling concerned that because we want to make sure that people who need help or need to get needed care can still get it. We have been messaging that NYC Well is available, and in part, I wanted to share those data with all of you because we don't think that means there's no problems, just that people are staying home, physically isolating, and they may experience more suffering by themselves. So we don't think of it as a success. We think, except the fact that perhaps we let the emergency departments left them a little more available to take care of physical health emergencies from COVID, but we'll continue to monitor it and continue to encourage people to seek help.
Great, thank you. In terms of, and this probably falls in the same category as my prior question, but do we have any data about overdose deaths? There's anecdotes and sort of stories that are going around, but do we have any data or anything that we can update people on the webinar in regards to overdose deaths?
Terrific. I'm going to actually ask Denise Paone, who I believe is also on, to answer that question.
Yeah. Hi. Hey. What we're seeing in the emergency department data is that there's a decrease, but we are monitoring very closely the fatalities, but we're just seeing a decrease in the 911 calls. So we don't really have the data that we really would like to have right now, but we're doing everything possible to monitor what we can, both EMS calls, emergency department, and fatalities.
And Kristen, if I can, let me just add to what Denise just shared, which is on the website I keep mentioning, in the section on prevention, there is information for people who use drugs and strategies that folks working with people who use drugs could use information to share that could reduce risk of overdose in a time of COVID. And we know that some of the very measures we're putting into place to reduce transmission of coronavirus, staying alone or staying apart from people, are potentially the exact ways that people could be at heightened risk of overdose. And so we make a number of suggestions in that very short document that could be useful to you in working with clients or participants.
Hey, thank you. If we can have Denise on mute again, thank you. So will city council contracts have the same flexibility as other DOH-MH contracts?
I believe at this point, unfortunately not, but I'm going to ask Cassie Toner also just to weigh in here.
Yeah, so we are still awaiting guidance, but as of now, no, we are not able to offer any flexibility to city council contracts.
Hey, thank you. Next question. Do we know if New York City hospitals have been engaged in trials with remdesivir, and given what we've heard on the news today about some potential promise early on in some work in Chicago? I wonder if we know anything about that.
So I don't know the answer to that question. What I will share with you, however, is that I am aware that there are many trials of a number of potentially useful agents happening across the city, including managing people in intensive care units, interrupting what's called which perhaps some of you have read about, the cytokine storm, sort of the overwhelming inflammatory response that perhaps is causing people to become so ill with their lungs, as well as other trials. And for folks, again, just to reiterate, I encourage you to, if you're interested, to join another physical healthcare provider call that the health department sponsored, also frequently on Fridays, and more of the treatment and of COVID is covered there.
Hey, thank you for that. We also have a question about testing, that we're hearing a lot about testing at a New York State level and just in national media. And is there any update around testing that we can share with the group?
Sure. So I know testing has been really since the beginning of the pandemic here in the U.S. has been a very difficult issue. We have continued to have real difficulty scaling up testing adequately because of very serious supply chain issues. That is, the materials that you need to both collect the specimen as well as the materials needed to run the actual test itself. And then finally, because of the way the test is collected, or at least sort of first generation tests are collected, the healthcare worker needs to be in full quote unquote PPE, meaning wearing a gown and a face mask and gloves. So all of this will change. We expect there to be next generation tests in which full PPE is not needed. There are various supply chain issues that are continuing to get worked out. And so testing eventually, I believe, will be available widely. The reason why it is probably less important right now is because in this moment of widespread community transmission, testing in a person who has symptoms consistent with COVID, even if it were not a positive test, even if it were negative, we might think anyway that the person had COVID because it is so common and we think that maybe the test is wrong. Once we move into the next phase of the pandemic, and we didn't cover this so much here, but certainly this has been what's in the media, that is a phase where we're able to suppress transmission, using testing as a strategy will be very, very important and will be a key part of us being able to loosen the physical distancing policies that are now in place. So I think that I'm optimistic that supply chain problems as well as new technologies will become available even in the coming days to weeks. And this is something all of us should, continue to follow. And I encourage you to continue to follow this both on our webpage as well as from the state.
Hey, thank you, Dr. Cummins. That ends our question and answer period, and I'll let you sum it up. And thank you for responding to all those questions.
Thanks, Kristen. Thanks, everyone who was on deck for me to phone a friend. I very much appreciate it. I really want to share with all of the participants, first of all, thank you for your time. All of us who are panelists today are here really working tirelessly to try to support all of you, and most importantly, all of the New Yorkers who you are caring for. We will continue to hold periodic updates as we feel like they would be useful. And again, thanks everyone for all your work and caring during this time. Have a good afternoon.